Hello, hello, hello. Happy Thursday, everybody. Very excited to welcome you to another round of Thursday VMR. I feel like these words are now just like placeholders every Thursday at 6 a.m. Pacific time, and I'm very, very glad that's the case. But there's nothing routine about today's gathering except the fact that it is yet again a star-studded lineup from the CP Solvers Academy folks. Today we have Julia scribing yet again as if like a Thursday routine and Anmol doing the teaching points. And I'd love to hand Julia then Anmol the mic just to say hi, catch us up on how life has been treating you this week. And we'll take it from there.
Hello, guys. I guess it's the best routine I can wish for on Thursdays, and I'm very excited as always for the case. And I'm probably mostly excited for Elena discussing today, and I know she will do really, really great. So yeah, I'm ready to go.
Hello everyone, my name is Anmol and I'm very excited to do the teaching points today. I'm on my night shifts this week, so I was just finding a slot where I can come and do an active role in the form of teaching points. So I'm super excited for Elena and Rahul to take away with the amazing case.
You guys are awesome. My story from this week is having a really cool EKG and just hopping onto Zoom with these guys. And I see Anmol walking around in the middle of her ER rotation. I'm like, Anmol, what is this EKG show? And she absolutely nailed it, which was which was really, really cool. But yeah, today we are all absolutely thrilled to have two people who are really dominating the show. First is Rahul, who is presenting a case. Let me hand the mic to you, Rahul, to update us on how things have been in your life and what recent major transcontinental changes have happened in your life.
Hello, everybody. I'm Rahul. Good morning, good afternoon, and good evening. Yeah, right now in India, I'm still jet lagged, trying to cope up. And I had a pretty bad sore throat. Yeah, but things are very great. And I've been learning, this week has been fantastic because we learned a lot about syndrome of inappropriate immunocorticoid excess secretion and a lot of, EKGs, a lot of cool stuff coming up on this weekend. And I'm excited to share this case.
Oh, well, thank you for that
So
secret
much.
plug to all the Academy learning. Yes, for those of you who are interested, hop on, present a case, type up in the chat. There's a lot more learning that we are all getting to do on the inside, and would love to invite all of you. And I'm very thrilled for that setup because I have to tell you that there's a very specific reason that Elle and I are discussing today, and it's both sad and great. Elena's about to go into residency in a very, very short period of time, which means, unfortunately, for the rest of us, unfortunately for her, we'll probably see her a lot less. And I think that's actually how the story of Elena and VMR began, is we didn't really see her much. She was hiding behind the scenes and slowly but surely made a gradual entrance to VMR, turning her camera on, starting to share her thoughts. And I think for those of you who have been part of VMR for a short period of time might be stunned to say that that's the case, as she's really become synonymous with the term CP Solvers VMR over the last few months. And it's been absolutely unreal to see, culminating, I think, in really spearheading a completely new initiative called the Student Forum, where all the students and CP solvers get together and do their own learning guided by our own internal experts who are also in their journey. And it's just absolutely unreal. So I figured we had to get one more discussion, Elena, before you get a lot busier. And I'm super excited to make it happen today. I'll hand the mic to you to say hi. I know the nerves are kicking in. And then we'll jump into Rahul's case.
Yeah, hi everyone. Thank you, Rabih, for that introduction. And also thank you to Julia and Anmol scribing today. And I'm super excited for Rahul's case. Yeah, I think I've talked about this like journey with a couple of Academy members, and I think it's yeah, it's sometimes more easy or more difficult for people to turn on their cameras or just be present to talk out loud. And for some, it's easier to do that from the very beginning, and for some, it's not so easy. And all of that's fine. And it's just a journey, and it's good to talk about this with other people. And yeah, I mean, when I look back on the journey that I've had with CPS, it's just that despite the growing that we all do kind of together, I'm just so excited by all the connections that I have made, and they're like really profound and strong. And I'm like super grateful to be here. Not only to the people who are part of the academy, but everyone who's here, who's like saying things in the chat, and yeah, just super grateful and excited to be here today.
Amazing. Well, thank you so much for all that, and I'm excited to jump into Rahul's case with you. Take it away, Rahul.
Sure. So this is the case where I saw in one of my GI rotations, and the current history starts in January of 2024. And the patient is 20-year-old male guy with a past medical history, I mean, with concerning complaint of mid-epigastric pain for 1 year, which is exacerbated sometimes by food or doing by exercise. And he also complains pain is intermittent and lasting for few hours and sometimes fluctuates, and he rates 6 to 7 out of 10 rate scale of pain, and it's exacerbated by pressing on the abdomen. And he also says that it feels like somebody's punching in his stomach. And he also has some occasional heartburn every other alternate week, and his PCP recently started him on PPIs. And he also has some decreased appetite due to pain. So this is the end of my first aliquot.
Off to a very intriguing start. Thank you so much, Rahul. Elena, where did your mind go with this?
So just to like see if I got everything. I think we have a young 20-year-old gentleman who presents with 1 year of epigastric pain that seems to be exacerbated by food intake and exercise, and the patient seems to also report of heartburn that is now treated with a PPI. Is that right so far, Rahul?
Exactly.
Okay, great. Yeah, I think there's really a couple of things that we can talk about here. Maybe we start with just the chief complaint, and I will layer in the age and the time course later. So I think with epigastric pain, we think of processes that happen inside the abdomen. With the localizing feature of the epigastrium, we think of structures that are there, namely the stomach, maybe the hepatobiliary system, but also pain that is maybe radiating from abdominal structures that are more caudal to the epigastrium. But also what I'm always thinking about in a patient who presents with epigastric pain is thoracic issues that explain the epigastric pain that could radiate to the epigastrium. So thinking of, for example, like a lower lung process or the heart itself. So this is kind of the etiologies that I'm thinking about, and then layering in that the patient is only 20 years old, I think is very interesting, because a lot of the things that we are thinking about, like things that increase the risk for cardiac disease are namely cardiovascular disease that come into play when patients get older. They get atherosclerosis. Of course, most of the time with young patients for cardiac pathologies, the same risk factors apply even if they're like only 30, but 20 is still pretty young. And I think another and maybe the most interesting aspect of this presentation is actually the time course. So 1 year would classify as chronic abdominal pain. And if you all think to yourself how many times you have seen a patient who presents to you with 1 year of abdominal pain, maybe you would say 1 or 2 times, because it's really unusual. And I think if we, in general, study chronic diseases, I think it's interesting to look at how this time course can help us? Is it like a gradual process that is increasing, or is it like an intermittent phenotype of a chronic process? And I think it's interesting to kind of study how a process can be there for such a long time without, we don't know that so far, without causing major consequences. And most diseases, for example, of the heart, and I think you and Maddie actually talked about this on Thursday, is as soon as they start to have symptoms, they would show up at some point and cause some sort of morbidity. But it seems like the patient has tried to seek care. So it's not like the patient has waited for a year, but has actually presented and the patient has gotten some PPI. So yeah, I think it's interesting to study just how this process could have has been there for like a year without any like further consequences. And yeah, I think those are kind of the things that I'm thinking about with this presentation right now.
Yeah, I think, Elena, that's a really a profound reflection on the diffuse localization of epigastric pain, which can be really thoracic or intra-abdominal, and intra-abdominal can range anywhere from the stomach, the pancreas, the liver, the spleen, all sorts of things. And so I think that when you realize that a patient is opening the door to many different diagnostic possibilities, asking yourself how you can make progress is really, I think, often made by the time course. And I think what you're fundamentally saying is, for a problem to be allowed to persist for 1 year, the study of what consequences it has led to will shed profound significance on the nature of that problem. And that's not a diagnostic luxury that we have with patients when they present hyperacutely or acutely, where there's not enough time potentially for any consequences to accumulate. And so I think, given that you have a whole year of disease, at least a year, if not more, of subclinical disease to deal with, I think studying the consequences, and what could they be? The consequences could be jaundice. The consequences could be reduced exercise capacity. The consequences could be iron deficiency, anemia, or weight loss. And I think right now it would be stunning to think this patient has no consequences, none whatsoever. And I think that would be a profoundly restrictive entity, where splenomegaly, liver disease, cardiac disease, pancreatic disease would be almost off the table. And I think really functional GI diseases or abdominal wall diseases would rise to the top. So I encourage all of you to do what Elena just did. It's really now, when something has evolved for a year, your ability to make progress will be able to be, are there consequences or not? And if there are consequences, what are they? And if it's iron deficiency anemia, you know what to do with the problems in the lumen. If it's jaundice, you know what to do with the problems in the liver. If the patient can't exercise anymore, you know what to do. It's a cardiovascular issue. So I think the study of consequences is probably even more important than the study of the nature of the disease, because they really declare it in a much more specific manner than the disease itself. So I'm really excited to study the nature of the epigastric pain, but to pick up any hints of consequences that Rahul lays on us. So yeah, hand the mic back to you, Rahul, for more.
Incredible discussion, Ravi and Elena. I loved your reasoning. And here is my second quote. And the patient has a past medical history of chronic mid-lower back pain and small left-sided hydrocele and bilateral varicocele in 1 year ago. And he started having some kind of testicular pain and swelling, but it denies any trauma to the scrotal area. And the urology recommended Tylenol for his pain control. Back in 2019, he had an ED visit for diffuse abdominal pain, and for which he got a CT abdomen and pelvis, which was unremarkable. And the patient was incidentally noted to have a left lower lobe pneumonia, which was treated empirically. And review of systems were normal. The patient does not have any no melena, no hematochezia, no early satiety, unintentional weight loss, or dysphagia. Coming to his medications, he takes ibuprofen 800 mg, few times a day for his testicular pain. And about 1 month ago, he started taking more of ibuprofen. And the family history, he does not have any family history of colon, throat, or stomach cancer. and is a social drinker and drinks 1 time a week, and his vitals are pretty stable. Physical exam wise, he has mid-epigastric pain on palpation. Otherwise, benign physical exam, everything is unremarkable. There is no guarding and there is no hepatosplenomegaly. This is the end of my second aliquot.
Rahul, may I just ask one really interesting question, which is when you first saw the patient, what was your estimate of his BMI?
Honestly, Ravi, I did not see this patient.
I see. Okay.
So I just want to tell you what happened at the
Yeah,
end of the session. Yeah, because this
that's
case
all.
was pretty surprising for me,
I
and
see.
I did not know anything about this case until I finished my last day of rotation. And
Amazing.
yeah.
Amazing. Okay, alrighty. We will proceed without that information, just like you did. All right, Elena, what struck you in this case so far?
Yeah, I think I was kind of watching out for associated symptoms despite the abdominal pain with this patient. And something in particular, when we think of abdominal pain that can clue us into a process that is deep, would be, for example, nausea, vomiting, potentially also diarrhea. And I don't see anything of that. And I think that together with the fact that the patient has presented before with a more diffuse abdominal pain, but still it seems to be like a continuous story of this abdominal issue for the patient. They have had a negative CT. And a lot of things we worry about can be seen on CT. Of course, it would be interesting to know if that was done with contrast or without, because the amount of things that we can see is the yield is way higher with contrast. So yeah, I'm actually, I think we haven't seen any of these consequences that you have talked about. We didn't see jaundice. We don't know about the BMI, but I'm kind of assuming that the patient is not experiencing significant weight loss. So I'm wondering how can we have a potentially abdominal process or maybe even a thoracic process that doesn't show up on imaging and is not really accompanied by features that would clue us into a deep process. I think something that I also wanted to talk about, because I think we didn't talk about this in the first aliquot, was the fact that it's exacerbated by food intake and exercise. And I feel like for the exercise, I don't know if I think I would really ask for the exercise tolerance of the patient. If there was if it has changed over the months or years for the patient. And usually when I think of exercise-induced pain, I'm localized at the heart, and this would be angina. To me, I think it's curious that it's not only exacerbated by exercise-induced ischemia, for example, but also food. And I think we have talked about this before, when you think of what happens when a patient takes in food, we generally think of the stomach, we think of the biliary system, maybe the pancreas, but there's something else that is important in this context, which is the vasculature. And in the context of food intake, the perfusion of all these structures that are involved in food processing need to be more perfused, and this could potentially cause relative ischemia to the heart, which could again point us actually towards the heart. So yeah, I think at this point I'm not really sure where to localize this problem. And I think for the back pain and testicular pain so far, it doesn't really help me, to be honest. I think I would be curious what the testicular exam is going to be like. Do we see any form of inflammation? Do we see edema? Something like that. And yeah, I think just one more comment on the ibuprofen. The patient is taking a pretty high dose on a more or less regular basis, which can make you prone to gastritis, also PUD, and the patient seems to has also some sort of heartburn. So I feel like there could be multiple processes going on here. Yeah, but I'm just really struck by the fact that this patient is really young. They have this chronic abdominal pain. It's intermittent. We don't really have a good explanation. Yeah, I'm just curious where we're going from here.
Yeah, no, I agree with you. I didn't really pick up any overt consequences yet, but I think it's very powerful to say, are there any subtle ones, such as loss of weight or adaptation to this consequence by the patient minimizing the amount they eat and maybe increasing the frequency that they eat? So if you ask patients with chronic mesenteric ischemia as a diagnosis that you're alluding to, how their behaviors change, they don't really, because of the chronicity of the process, their behavior changes can be very, very subtle. And so I think that really there's nothing screaming out to us, but does that mean there is nothing, or does that mean we need to start to use a microscope to detect that? And that's where I'm at now. And I think the reason that I would be interested in studying any medical history clues is to say, is this truly chronic abdominal pain, or is this subacute and slowly progressive? Meaning, is the line flat and this patient's going to have discomfort for 2 years, 3 years, 4 years? Or is the line progressive and the patient's going to have much more overt dysfunction soon? And I think you scrutinize everything that you get, including subtle histories on history, subtle pieces of history that are lurking in the background. And I think one of them is that the patient has varicoceles. So for the sake of time, I'll just jump in and try to explain that, because I imagine we have a lot of stuff to get through. So it's very, very common to have varicoceles. And the reason we have varicoceles is because the testicular veins are relatively vulnerable to higher pressures. And it's especially so on the left testicular vein, which drains into the left renal vein. And the left renal vein then drains into the inferior vena cava. And that tortuous circular indirect route that vascular takes predisposes the patient to have isolated venous hypertension, causing a varicocele without really any other explanation apart from that anatomical complexity. However, a right-sided varicocele is pretty unusual, and it implies that there is venous hypertension affecting the IVC and the right testicular vein. And so I think that as a general rule of thumb, it's important to recognize that varicoceles are common, and so it can be pretty easy to get dulled into their existence. But if you define the problem better, you'll recognize that isolated, slowly progressive, left-sided varicoceles are pretty common. In stark contrast, the abrupt development of any varicocele on any side is alarming, and the presence of a right-sided varicocele is alarming. What would be most alarming is if the varicoceles do not improve with lying flat. Because if you're just invoking subtle anatomical issues, the patient should lie flat, the intensity of the venous engorgement should reduce. So I think that there's a subtle signal here to intra-abdominal hypertension, either a primary venous issue intrinsic to the IVC or the right-sided testicular vein, or one that is externally compressing those structures. And so when you start to think about external compression, you start to think about really scary hypotheses like cancer. But I think if you were to try to take this aliquot as far as you can, you might start to wonder, okay, I have to worry about scary space-occupying things, but are there subtle things that can cause subtle compression for a long period of time? And I would go into the exam with that hypothesis and bring with me the fact that this patient has low back pain and how to integrate those two things. But I'll pass the mic to you, Anna, for any comments or questions, because this truly in real life would just be speculation. So I wouldn't draw it out in real life when I'm taking this patient. I wouldn't spend 20 minutes thinking about it. I'd be like, that's weird, and proceed to use that as a potential clue. But I'm curious what thoughts or questions you have.
No, this was a great explanation. Yeah, I think I haven't put too much emphasis on the varicoceles. I just like kind of put them to the side. But yeah, I think I'm curious how this could be in line with the current presentation of the patient with the epigastric pain. If we are, for example, invoking like a retroperitoneal process. Yeah.
It's a great summary. And for all of you listening, I encourage you to be very, very careful when you hear lower back pain. And I appreciate Rahul's clarification that this is mid lower back pain. And that, Elena, is yet another soft clue because it's pretty unusual for patients to have back pain that is anywhere but the lower back, especially when they're 20. So the truth is that I think we're probably making more out of these than you probably would if you're Maddie in a very busy urgent care today. But the truth is that subtle things can, these small subtle things can have a profound impact. If you're moving quickly, low back pain is just low back pain. But if it's mid low back pain, if you're moving quickly, a varicocele is just a varicocele. But if it's bilateral, And so that's what I'm doing with these things. I'm like, they're pretty common. They may just be twisted versions of something that's common, but I hope there's nothing actually twisted on the inside. All right, Rahul, mic to you, my friend.
I loved your thoughts, Rabih and Elena. And to answer your question, Elena, the scrotal the genital findings were pretty unremarkable. The patient did not have any kind of signs of inflammation, no edema, but it was mild varicocele. And yeah, this mild varicocele, and he was complaining of slight pain. But other than that, other than epigastric pain, the rest of the physical exam is pretty unremarkable. And moving on to the next aliquot. And as I mentioned, he got CT abdomen with contrast in 2019, which showed a left lower lobe consolidation. And 1 year ago, I mean, back in 2023, he got an ultrasound scrotum with Doppler, which showed small left-sided hydrocele with mild bilateral varicocele. And 7 months ago, he got another CAT scan and abdomen with pelvis, which was within normal limits. Is CBC, chemistry, urine analysis, CRP, ESR is normal. And he also got an upper endoscopy, which is unremarkable, no evidence of H. pylori or celiac disease. And GI recommended a trial of FD-GORD and follow-up with urology for testicular pain. So this is the end of my third aliquot.
What do you think, Elena? What happened there?
Yeah, I think there's a lot of, I mean, there's not a lot of new information, but yeah, just the confirmation of the ultrasound of the there's also like a hydrocele and this like bilateral varicocele, and just the fact that the patient had like further workup done, they had like an upper endoscopy, which actually didn't show any signs of why the patient would have like heart pain or epigastric pain. So another pertinent negative, if we like look with our own eyes and not just a CT on why the patient could have this epigastric pain or abdominal pain. I actually don't know where I would be moving from here because the labs are pretty much negative for any kind of inflammation, any changes in the CBC, any kind of electrolyte disturbances. Yeah, I think maybe there's I mean the last CT was like 6 months ago, so I don't know if I would be inclined to repeat it. Yeah, I would probably ask you.
No, I think that you're onto something here, which is I think that the truth is this patient has had very, very thorough investigations. And the question is, how much juice do you try to get out of the things that you found? And if you heard bilateral testicular pain, heard varicocele, you image the patient, you don't find anything, I think that there are, of course, holes in that analysis and you could have slipped over something. But I think this is a time where the evolution of the disease will probably be most important. And so if we later learn, hypothetically, that 10 years from now, hypothetically, he still has mild epigastric pain, he's not feeling great, but his labs are still normal, his CT is still normal, and he has the same findings, then you would be like, yeah, I don't know if I'd be able to get to the bottom of this with more precision with modern day tools. And so I think it's really all about how this disease evolves. And I think it's hard to imagine how it's going to evolve in a sinister way because of the fact that it seems to have a tail all the way back to 4 or 5 years from now. But I think the threads that we could pick up on, should the patient decompensate or evolve in any way, is what's up with that left lower lobe process? Why does he have mid-low back pain? Why does he have varicocele? And I think all those things may just be unexplained. And so I think what I would be doing right now is just to really apologize to the patient for the fact that they're suffering. And I would feel pretty bad about it. And I think I would just schedule a short interval follow-up with them to see how things evolve, recognizing that in an overwhelmingly probable scenario is if an answer hasn't emerged with looking on with inside the abdomen, the CT scan and endoscopy, that it may not ever emerge. But I think you have to be humble and be open to that possibility. So I'm like you. I would reinforce what you just said, which is I'm not sure what progress we can make, except to say, hey, this, whatever this is, it's really, really hard to find. And you don't seem to have lost a terrible function from it in your ability to eat, in your ability to walk, and your ability to talk, which are the three things that we really try to save for people. And so as long as it can eat, walk, and talk, I think that I would probably watch how this pans out.
Yeah, so the patient has been having these similar intermittent episodes of abdominal pain again, and he was following with the outpatient with GI and his primary care clinic and with urology. And GI doctors ordered some other investigations, and he said the FD God is not helping him much. And he also got fetal calprotectin, it was negative, it was normal, and negative alpha-gal antibody, and negative urine porphobilinogen. And patient agreed, and the GI doctor recommended a trial of duloxetine 30 mg at bedtime for a possible brain-gut interaction. And he also said it did not help him much. And later, on further discussion with the patient, and GI recommended CT angiogram of the abdomen. So this is the end of my fourth report. Would you want me to give the more detailed information so that?
Oh, this is fun. Hey, however you planned it, Rahul, I know you're a pro at this, so we'll go however you want to.
Yeah, sure.
Yeah, so we can stop here. It's totally okay.
That's fine.
Yeah, just go whatever you had planned. We're dancing with you no matter what you want to do.
Yeah, sure. And he got a CT abdomen and a CT abdomen angiogram, which showed a mid narrowing in the proximal celiac artery with a slight hooked appearance. So that was a CT angiogram finding. So I'll stop it here.
All right, Elena, what are you making of that?
Yeah, so the team got a fecal calprotectin, which is usually a great marker for any kind of inflammatory but also infectious processes happening in the GI tract, which is normal, sort of reassuring. They also got like porphinogen, which could be an interesting explanation for like chronic intermittent abdominal pain, which is usually accompanied by some other features. We had an interesting case on a Sunday VMR a couple of weeks ago. And then for the CT angio of the abdomen, we have like what I would describe as some anatomical variant in this patient, some narrowing of just one like one spot of the artery, which I don't know what I would like do about that. I think, yeah, the narrowing could be just like an anatomical variant. Of course, you could also get like a narrowing in the context of like atherosclerosis, inflammation, but I'm honestly not really thinking of that, but more of yeah, some kind of something that actually has been there for probably quite some time. Yeah.
Oh no, that's a really outstanding interpretation of this. Because we have a little time, I would just love to query really like your meta thinking here. How are you feeling about articulating your thoughts in this case compared to other cases? How would you compare the challenges that you're feeling this time around to compare to other instances?
I feel like I think many times we have a lot of information that we can put together or like tear apart, and we can look at them from a wide variety of perspectives. But I feel like in this patient, and I feel like if you're running and I feel like you're halted, that's kind of how I feel discussing this patient.
Yeah, it's very, very tricky, I think, to really ask yourself what to focus on and what to take on, even now, I would say, even for this finding of this narrow proximal spheric artery. And I'll try to explain why. I think, Elena, we talked about this on WhatsApp. I think it's hard to know what the problem that we're trying to solve is. Is this chronic abdominal pain? And the word chronic implies a flat line, that the patient will have nothing more except abdominal pain forever. Or does this patient have a subacute progressive disease? I think 5 years without the patient being in absolute crisis with no weight, no BMI, no anything, is a very, very hard diagnostic space to solve. And so I think if you go back to the varicocele and the introduction of either a problem in the vein itself or a problem with external compression, and we divided external compression in that space to something very sinister, like in a 20-year-old man, gosh, testicular cancer would be something to worry about right away when you see that. And then but then we were like, okay, well, that doesn't make sense. This is an indolent disease. So what kinds of things could could cause external compression in a more gentle manner? So if you were to start to go and think about that, like how could somebody have external compression of a vessel with gentleness and therefore sneakiness, subtleness? What do you think?
I think for like to like answer your question, I think of processes that could be like fibrosing in nature, and then also just I think we have a lot of space occupying lesions that are not non-malignant. So when I think of cysts, adenomas, and also sometimes we can have like inflammatory tumors that can just be there in the context of, we see that, for example, in pancreatitis, where we have lesions that actually look like a tumor, but they're just benign inflammatory processes, but they can also like be space occupying and potentially compress on structures, causing, for example, narrowing or any other issues. Yeah.
Yeah, I think that the term fibrotic is probably a very helpful adaptive term in general to apply anywhere. I think osteoarticular compression is a particularly important one. But I would say whenever you're entertaining the abdomen, I would love all of you to think about one thing, which is the loss of the protective effect of abdominal fat. So the abdominal fat is a very powerful thing that keeps things steady and non-compressed in the abdomen. And there are so many syndromes that develop as a loss of the protective effect of abdominal fat. Do you happen to know any of those syndromes or have heard of any of those syndromes, Elena?
I think the first thing that would come to mind is anorexia nervosa.
Yes. So what happens is in a disorder, like eating disorder, that causes weight loss, a vicious spiral is ensued. Because a vicious spiral causes loss of the abdominal fat pad, and the loss of abdominal fat results in compression of vessels by structures that should not compress them. So a great example of this is SMA syndrome. Have you heard of SMA syndrome, Elena?
No.
Well, you have now. So what happens is the SMA forces very close to the proximal duodenum, the superior mesenteric artery, and the loss of abdominal fat pad causes the SMA to compress on the duodenum, causing gastric outlet obstruction. And who does this happen to? As you just said, it usually happens in patients with chronic weight loss like anorexia nervosa. And anorexia nervosa creates the loss of the fat pad, causing the SMA to no longer have cushioning between it and the duodenum. Boom, compresses the duodenum. And what happens to a patient who has duodenal compression? What do you think is going to happen to their anorexia nervosa? Skyrocket. Vicious, horrible, 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 vicious cycle. But guess how it progresses, Elena? 1 adipocyte a day. Slow and sneaky. So, here, 1 sec, sorry. I'll be back. All right, sorry. In full disclosure, Kara is going in for a 28-hour call, and I couldn't not give her a hug before she went. Yeah, abdominal fat is a really important thing to track, and I think I don't know when we have a right-sided varicocele and a left-sided varicocele that is sneaking up on us without clear explanation in a young, otherwise healthy person. What else can happen is actually you can get compression, very, very subtle compression of the renal veins in a syndrome called the Nutcracker syndrome, where in that instance, the compression of these structures, essentially by aorta and other vasculature, causes low-grade renal venous hypertension. And that renal venous hypertension can manifest in some subtle ways, including hematuria, which this patient doesn't have, but also varicoceles. And so I would love for you to take that hypothesis, and which is why I think I cannot imagine. I'm trying to imagine this patient. I cannot imagine him having anything but a low BMI. And the truth is, we don't have to see him to do that. You can look at his CAT scan and see that he probably has very minimal fat. Of course, we're speculating, but if I were to try to bring this patient to life, I am making an assumption that there's very little intra-abdominal fat and likely very little fat anywhere else. And so now I want you to take that hypothesis and how that influences your analysis of the CT angio finding. What do you think of that?
Yeah, so if I understand this correctly, then the fat has like multiple functions, but namely to hold organs, arteries, and all the structures in place. So the narrowing could be actually from compression from like another organ or another vessel. So yeah, it's a super interesting hypothesis and really is in line with the time course of the patient, right?
Exactly right. So what you said, I want everybody to hold on to and not get too carried away about what I said. Because the truth is, in most instances, when you see small narrowing of the proximal celiac artery, that is actually an artifact. It's not real. Why is it an artifact? Is because when we breathe, the diaphragm compresses on the celiac artery in a very natural way. And so this is often an anatomical variant of no significance. However, the only time it could be of significance is this case, where a patient has slowly progressive epigastric pain and discomfort. And in a patient who already you have the hypothesis that they have lost the protective effect of fat, here the inlet to that hypothesis is not the epigastric syndrome, it's the varicoceles. And so we're entertaining that the unifier of the venous hypertension in his testicles and the arterial insufficiency potentially of his epigastrium, what brings them together is not a massive mass that bridges the renal veins and the median arcuate ligament. It's actually the loss of something in the abdomen, and it's the loss of the abdominal fat. And so how do you bridge your thought, Elena, with the thought of abdominal fat? Because this could be an anatomical variant. You have to prove clinical significance of this finding, because the treatment of it is significant surgery. And so how do you prove that this is actually causing consequences to the patient? And the first thing is you prove that the patient doesn't have anything else causing their symptom complex. And Rahul has done that expertly with his very subtle, strategically timed aliquots, telling us it didn't get better with PPI, it got an EGD, all that. But there are a couple of other things you can do. The timing of the CAT scan. I forget exactly the details, honestly. I have to refresh my memory, and I won't do it now, about when the diaphragm is pushing on the celiac artery allows you to make more significance. But an ultrasound is a really, really key test, because if you see on ultrasound an increase in the velocity, that shows that that's not actually an anatomical variant, that there is actually significant stenosis there. And at some instances, people go to extraordinary lengths to see if this is clinically significant. And they do actually gastric tonometry, where the idea is that your stomach stiffens up and moves less well if it's relatively ischemic. And so we'll measure transgastric tonometry to see, is there significance of this? I've actually seen one case, not seen, but I had a CPS case at UAB where they did a celiac access nerve block, and they blocked the nerves that are potentially ischemic by this artery, and the patient had relief of pain. And that's what made them comfortable to then pursue surgical correction. So I think the summary is the veins are an inlet to loss of abdominal fat. Median arcuate ligament syndrome is a syndrome that describes compression of the median artery, a median ligament, cruciate ligament on the celiac artery, causing a chronic mesenteric ischemia picture. It classically occurs in young patients with low BMI. And so, as you said, oh, your initial reflex answer was anorexia nervosa. We still have to ask, why did this patient have, if he has weight loss, which he likely has, what was the initial cascade of it? And I think that I think I would be very, very careful not to overlook, just because this patient doesn't report any alcohol use or anything in the world of nutrition. I think it would be a mistake not to visit that with the patient at some point, to be like, what are your eating habits? What are your substance habits? Because the initiator is often something proximal to the loss of abdominal fat, and knowing what that is really, really important. So I've said a lot. I'm really, really curious what questions you have, Elena, and before we pass the mic to Rahul.
You know, I don't think I really have a lot of questions. This is like a totally new space. And I knew that Rahul's poker face was going to stretch me today. So yeah, excited for what you and your team did next.
Incredible discussion so far. I loved your thoughts. It completely blew my mind today. Thank you so much. And this is going to be my last telequad, and it's going to reveal the diagnosis. And because of the CAT scan findings, CT abdomen angiogram findings, and the primary care, the GI team recommended to see the vascular surgery, and the vascular surgery recommended dynamic mesenteric duplex for the further evaluation, and also recommended to continue the duloxetine 30 mg. And the duplex showed 70% stenosis of celiac artery at its origin, most likely related to the extrinsic compression. And this is aggravated in a forced expiration position, where his peak systolic velocity rises to 317 centimeter per second from 228 centimeters per second in a neutral position. And there is no evidence of superior SMA or superior mesenteric artery or inferior mesenteric artery stenosis. And based on these findings, the GI recommended a celiac plexus block. And he got a celiac plexus block on the EUS, but unfortunately, it did not help him much. And the team finally made a diagnosis of MALS, which is median artery ligament syndrome. And soon he's going to get a surgery of all the tendon or the ligament release at Yale University. So this was one of the fantastic case I've seen, but you nailed it. You nailed it, Elena, and all the big shout out to all the chat. And yeah, thank you so much.
Absolutely outstanding case, and really, really educational, Rahul. Elena, what are you thinking?
Yeah, this was really, really interesting. And I think I have had the opportunity to discuss a couple of times in the last few weeks. And I feel like the cases that are not as clear to you, are not as familiar, it's the ones that you learn from the most. So Rahul, I'm super, super thankful for you bringing the case today. And I think I'm going to think a little bit more about just how the chronicity will help me with like future cases of epigastric or diffuse abdominal pain. But just the fact that the only really consequence for this patient was presumably, of course, the pain, but despite that, probably the weight loss. there was nothing else. If this would have been from like a vascular etiology, and the stenosis would have been intraluminally, the patient would have had consequences. And just the fact that it was like a dynamic stenosis from like external compression, I feel like was the opportunity to not have like further ischemic consequences for this patient. Yeah, but a lot to reflect on. Yeah.
Yeah, I think I don't know the journey towards what you laid the foundation for how to solve this problem, which is you're like, I know the organs that can cause epigastric pain, but I know this has been going on for a year, so the consequences will help me. And I think that's amazing to see how subtle the consequences can be. And I think that it goes to show you how invoking vascular disease, which is a very well described consequence of epigastric, or cause of epigastric pain, how chronic vascular disease can be very, very sneaky. And I think that you used actually perfectly the analogy of when heart disease becomes symptomatic, say coronary artery disease becomes symptomatic, it often takes off. But I think this is a great reminder that patients can have other mechanisms apart from atherosclerosis of their chronic vascular disease. So we often think, oh, a patient has a chronic vascular disease, it must be atherosclerosis. But I think external compression is a other mechanism that actually often tends not to progress at the rate of CAD when it becomes symptomatic. And a great example of this that's even more sinister than the diagnosis we made is anomalous coronary arteries. And if you all remember the case that that was on subspecialty VMR, I think Dan presented it, where the patient had symptoms since childhood, but without an aggressive takeoff. And so I think that the reason we didn't pick up consequences overtly is because the nature of this disease is slowly progressive over decades. And so I liken to think that true dementia-like progression of vascular disease is external compression by subtle things. In the world of anomalous coronaries, it's actually often the myocardium or other larger arteries like the pulmonary artery. And here in this case, it turns out to be the median arcuate ligament. So I wonder what the explanations are for the bilateral varicoceles. I can only speculate. I just wanted to be, I think the chat is being like crystal clear on a key concept here, which is that the value of surgery for these syndromes is variable. All these syndromes that we've talked about, I just looked it up while we were talking. So the average BMI in a patient with nutcracker syndrome is 18. The average BMI of a patient with SMA syndrome is 17. The average BMI of a patient with median arcuate ligament syndrome, at least according to open evidence, is 22. So in each of those circumstances, the compressor, what is actually causing the compression, can independently do the compression without the loss of the fat pad. So you can actually have an aberrant SMA compress on your duodenum because of the takeoff of the SMA. You can actually have abnormal osteophytes or other things compress on the IVC. And so I think incorporating the loss of the fat pad as either a causal mechanism or contributory to an anatomical variant is really key. And I think in median arcuate ligament, the emphasis on the compressor, i.e. the median arcuate ligament, is high, which is why, unlike those other things, the success of surgery for release is much higher than the success of surgery for SMA syndrome or for nutcracker disease, because the root of the issue is, in those other instances, is a loss of the fat pad. It takes up much more of the cause than the compressor itself. So if I were to sort of fine-tune the teaching about the loss of abdominal fat, it can account for 99% of the issue, which is often the case in SMA syndrome, 80% of the issue, like in the case of nutcracker, or 50% of the issue in median arcuate ligament syndrome. And I think the success of intervention has to be related to the success of building up that fat pad. And so you'll find that the distance to surgery for SMA syndrome is very, very large because you really need to restore that fat pad before you offer any anatomical correction. It really is that fat pad versus what we're seeing here in Rahul's case, where the distance to surgery is much narrower because of the effects of the median arcuate ligament. So I've talked way too much. I'm curious, Rahul, what was your takeaway? What did you learn from this case? How did you even hear about it?
Yeah, honestly, Rabi, and I was doing my GI rotation, and me and fellow and I was talking about the cool, interesting GI case, and he started talking about, and he actually he called the patient every week. He takes some time off, and he talks to the patient how he's doing and everything because he got the celiac plexus block. And he was talking about, Rahul, have you heard about this case of median arcade ligament syndrome? I said, no, I heard about median arcade ligament, but not about the syndrome. And then he started sharing about the case. And then I saw, okay, I went to the literature and I thought it's a great case and a phenomenal case to learn and share with you all. And that's how it started. But I can't imagine how hard the patient suffered. I mean, he got the first CAT scan in 2019. It means the problem has started from 2019. And I was wondering if I was in the same position, if I was in the same, as an intern, am I really going to expect this kind of, the progress in the patient's pathology? But because of his because he got celiac plexus, but it got some relief. But I'm very glad that he's going to get his surgery and is going to get better soon. And that was a big learning point for me. And I got few teaching points for all of you. If you have time, I can share my PowerPoint.
Please.
Sure. Can you able to see my screen?
Yes.
So the median arcade ligament syndrome is also called as celiac artery compression syndrome or Dunbar syndrome. This is the normal. I got the good picture for all of you because the diaphragm, the aorta passes through the diaphragm at the level of T12, and it has a fibrous sheath which is encroaches. I mean, it won't compress it, but this is the place. It is a normal location. But if you look at closely, zoom in, and there is some kind of compression. The fibrous sheath is compressing the celiac trunk. And this other image where you can clearly see the kind of the ligament is compressing the celiac artery here, and the exact sheath is covering the celiac artery. And in majority of populations, the ligament does not encroaches the celiac artery and won't cause compression. But in 10 to 24% of the population who have median arcade ligament compression, they won't have any symptoms. And the pathophysiology is very complex and it's not clearly well studied. And the proposed theory is because of the compression of the celiac artery causing the foregut ischemia and pain, and also the overstimulation of celiac plexus with splanchnic vasoconstriction. And there is a recent study that the median arcade ligament syndrome could be proposed with neurological hypothesis. Um, and and also because the diagnosis that if the making the diagnosis of MALS is very difficult, and it's called as a diagnosis of exclusion. And there is, as per demographics are considered, and it's more likely to be in the females than the males in the 4:1. The main chief complaint would be 91% would be abdominal pain, 62% would be having postprandial pain, and 32% have kind of post-exertional pain, and nausea, vomiting, unintentional weight loss, and exercise-induced pain will be also there. As I was mentioning, the MALS is related to some kind of neurological process, and the literature says a patients with if the MALS, the patients with autonomic neuropathy, including postural orthostatic, orthostatic, tachycardia syndrome, have been diagnosed with MALS. And the diagnostic modality, as Ravi was talking about, the duplex ultrasound, the deflection angle of the 50 degrees, and the expiration of the peak systolic velocity of greater than 350 centimeter per second, which equates to 83% sensitivity and 100% specificity for mals. And other CT abdominal angiogram and DSA would be help. And the management would be the release of the arcade ligament either through open procedure or laparoscopic procedure with celiac gangliectomy. And this is a flow chart which really shows the schema of diagnosing median arcade ligament syndrome. As I was telling you that median arcade ligament is a diagnosis of exclusion. Once we rule out every other possible etiologies, and we can go for the duplex ultrasound or angiography. And Ravi was also talking about the gastric exercise tonometry. And then once we have evidence to support the celiac artery stenosis, and the surgical option is the best for to get rid of the symptoms. And that's all I have. Thank you so much.
Wow, masterclass on the celiac artery compression. That was amazing. Thank you so much, Rahul. The visuals were really, really cool. Anmol, I'll hand the mic to you to sort of summarize your favorite teaching points of the day.
Thank you so much. What an amazing case. Made my day totally. And Elena inspires me every day as well. And so it made me realize that a simple complaint like epigastric pain can range from so many issues to benign to dangerous issues. So it could be anything from intra-abdominal to thoracic issues. Intra-abdominal can be pancreas, liver, and spleen. Time course in this patient was big, so we thought that we need to look for the consequences of the chronic illnesses to actually understand the nature of the disease. We realized the patient had varicocele. Varicocele, it made us think of some sort of obstruction, because left-sided varicocele is very common because of the anatomy of the veins. On the left side, we have an indirect tortuous route, which leads to venous hypertension. So an isolated left side varicocele is common. But in this case, we had bilateral varicocele, which made us think if there is some sort of an external obstruction in the form of a space-occupying lesion or a testicular cancer, which can lead to this presentation. Then we thought that what could compress a vessel gently. Then we started to think about some syndromes, which can happen when we have loss of protective effect of abdominal fat. The syndromes could be SMA syndrome. And what happens in that case is superior mesenteric artery, because of the loss of the protective fat, compresses the duodenum, which leads to duodenal obstruction. So in the VIPO, the O cause, obstruction cause is there in SMA syndrome. So it's important to know the BMI in this case, if the patient is eating well or not, because this happens in the cases of low BMI. Then we had another syndrome called nutcracker syndrome, when the left renal vein is compressed by two arteries. It's basically compressed between these two arteries, aorta and SMA, and it can lead to multiple presentations like hematuria. And then ultimately, we realized the patient had CT angioabdomen showing narrowing of proximal celiac artery with hooked appearance. We thought that this can be common in some patients, but we cannot ignore this finding in this patient because the patient is symptomatic. So we need to evaluate further. And then we realized that we can understand that in the VIPO mnemonic, the V, vascular phenomena, could be the cause. The celiac artery could be narrowed, which can be because of some cause, which can lead to the presentation, the abdominal pain. So median arcuate ligament syndrome is when the median arcuate ligament in the diaphragm compresses the celiac artery. That was ultimately what we found the diagnosis, and our takeaway was that the vascular causes, we mostly think that they could be due to atherosclerosis, but in the vascular cause, we mainly need the narrowing. So it could be due to chronic atherosclerosis or an external compression from the outside. So in this case, it was an external compression leading to the vascular cause of the abdominal pain. And ultimately, we realized the treatment for it is celiac gangliolectomy. And I learned a lot. I have to reflect so much about that. Thank you so much.
Last words to you, Elena. That was awesome.
Yeah, thank you all so much who made this session possible today. I'm beyond grateful. Thank you to you, Rabih, for guiding me, guiding us all through these Thursday VMRs. It's such a pleasure and such a privilege. I hope you all have a wonderful rest of your day.